Well, first, why contact tracing could be a game changer for getting ACC work-related illness cover, and how it's reigniting debate around the inequities in ACC's causation-based compensation system. For the first time, contact tracing could provide prima facie evidence around whether catching a virus like COVID-19 is work-related. This means the likes of health workers, flight attendants or supermarket workers could more easily demonstrate whether they are eligible for cover. Already, ACC has received 8 claims in total for COVID-19 infection, and of these 5 have been accepted, 2 are still being investigated, and 1 has been declined because the claimant did not contract COVID-19 following exposure at work. But that's of no benefit to partners or children of essential workers to whom they may have passed COVID-19 onto. Barrister and researcher Warren Forster says these new complexities once again raise the bigger picture of problems of a system that is based on cause. He says the flaws are similar to what was exposed during the Christchurch mosque shootings, where ACC could help mentally injured survivors on their way to work, but not those who were mentally injured passers-by. He is currently developing a proposal for expanding ACC coverage through a Law Foundation International Research Fellowship. Good morning.
Morena, Catherine.
Let's look at how contact tracing is showing up yet again the inequities between 2 people with exactly the same illness, one able to prove they contracted it at work and the other not.
Well, this system, like all systems, is based in legislation, so we go back and see what the law says. And in this case, the law's fairly straightforward. It says that if you're employed in an environment that has a particular thing in it, in this case it would be COVID, and that isn't around your home, and then you catch it, then you can be covered under Section 30. It's a little bit more complicated than that, but that's basically what it says. And then the question is, how do we prove that? So often when it comes to work-related injuries, the challenge is trying to prove how things happen. So here we have, through the COVID tracing system, not guaranteed certain evidence, but a prima facie case that I was in contact with someone at work and that's how I got it. And what that means is that you don't have to take sick leave, the health that you get from ACC's gold standard, and you get compensated at 80% of your income. But obviously, what we're seeing in the numbers coming through, I think that you said that there was 8 claims. We know that there was 40 aircrew staff and untold police officers and security and health workers and so on. So, again, there's a big gap there, and we don't know why there's a gap. But really what we know is that you can get cover, and contact tracing helps you get there.
We think of ACC first and foremost with injury caused by an event. Illness is covered, providing you can prove you got the illness at work.
Yes, and actually there's another interesting wee section called treatment injury. If you got the illness through treatment as well, then that's another way that you can actually get it. And the interesting thing about treatment is that when the law was changed in 2005, it specifically expanded it out to cover your spouse or partner and your children and people through that system. So the downstream effects of treatment injury, if you were to be infected through treatment, would be cover. So this raises a whole... For others. Whereas if I got it through work, the others don't get cover. So again, there's even within the legislation...
Not only that, the illness, in the illness example, if you can prove you got you got COVID-19, say, through being at work, and contact tracing is what will pin that down, in this instance, even if your spouse and children got it, they wouldn't have cover.
That's exactly right.
Whereas had you got a similar event through treatment, they would get it anyway, even though they weren't actually directly ill.
Yes.
So there are all sorts of randoms.
Absolutely. And what we see with the legislation is what I call a piecemeal or ad hoc approach. So something changes and let's change that little bit of legislation to address that exact problem. But the wider problems are far wider. And we see an example of that here, whereas if it was treatment, it would be covered and your family would be covered, whereas if it's work-related, it wouldn't.
So community transmission, if it's deemed to be community transmission, any COVID case, it doesn't count. Is there something from the contact tracing system that's being introduced with COVID? I mean, it's very labour intensive and it is probably going to be specific to a pandemic. We've got a little bit of technological support coming through, but relatively low intake. But is this something that could be extended, practically extended in other kinds of work-related illness in the first instance, or is this going to be a one-off that's just showing something up?
Well, the answer is it depends. So if it's something like a health worker at work who through treatment or treating someone through their work has HIV or hepatitis C or something similar, then that's something that happens all the time. And we do what we can to limit it and to be safe, but sometimes these things happen. So it is something that's ongoing. And from the same approach, the common flu, if you got flu from work, technically you would be covered. The problem we have is proving it. And that's where COVID's very different. We're not introducing a contact tracing app for flu.
No.
And obviously there's limits to this, but we need our law to be able to cover situations as they arise, and that's one of the key things.
Also, just how difficult is it often for people to prove any illness they have is work-related? I could see someone, I don't know, with asbestosis perhaps having a claim if they had worked for an asbestos-related company for many years or in a building. But I could see someone with another kind of cancer, perhaps a rare cancer, having a real struggle trying to prove a connection.
That's exactly right. And if you take that asbestosis example, recently we had a case where a man went home and hugged his daughter, and his daughter developed cancer as a result. So it's exactly the same situation. It's the flow-on effects of that. And you know, we really need to sit here in New Zealand and say, what are we going to do as a society about this? How do we deal with these issues when they arise? And one of the things to remember is that we're asking our supermarket workers and our healthcare staff to go to work every day and look after us. And we need to think about what are we doing as a society to make them feel safe and to make them feel supported because of the risks that they're taking.
Do you see around the world we have managed to bring our outbreak down to a very, very limited degree currently, thank goodness. But do you see around the world, if you look at what has happened in some other jurisdictions, and goodness knows what could yet be our future if we cannot get a vaccine and have to learn to live with this, could you see examples where it would actually be a very significant number of claims and a significant life impact for the worst affected people, with ACC very much in play?
Yes. What we're seeing internationally is all kinds of problems starting to arise now. If you don't have to look very far to some of the more litigious societies in the world, and how they're responding to outbreaks and addressing causation. So there's workers' compensation systems in the US that are grinding to a halt now, trying to work out how they're going to respond. Issues around causation are coming through there every day, and you know, I can see litigation around this going long into the future because, you know, in New Zealand we separate out what I call the fault-based mechanisms, which is how WorkSafe operates. So WorkSafe, it's their job to keep us all safe at work. We separate that out from the compensation through the ACC system, but in lots of other places these two things are combined. So you go to court and you fight about whether or not you got it through work, and we use that as a regulatory tool.
Look, we know there were fatalities among healthcare workers very high. I think in Italy was it 8% of cases were frontline health workers, right? So again, if we ended up with an awful outbreak here, we hope we don't, but we cannot rule out that we're going to have to deal with this in the future, then ACC would be significantly in play.
Absolutely. And one of the other things to bear in mind is it's not just healthcare workers who are infected. It's the psychological issues would also come in. If you're a healthcare worker and you're dealing with these issues and all the ethical and moral issues about who you treat and who you don't and who has a ventilator and who doesn't, the work-related mental injury aspects of that down the track will be very, very significant.
I've just seen a case of that in the United States just in the last 24 hours, actually, of a fatality, regrettably.
Yes.
You also mentioned the mosque example, and here we are, people on their way to work who witness these events and stop and help,
yes,
get ACC cover. People who are just passers-by doing something else, no, you're excluded.
And people in the mosque who weren't actually shot themselves, the same thing. So there's very, very significant issues when you're dealing with the boundaries between systems. And I'm not for a second saying the health and welfare system didn't do their best, but all they can do is follow the law. And one system provides wraparound support in a person-centric way and one doesn't.
Which is the nub of it. I was thinking the White Island disaster, actually Whakaari White Island disaster is another example of different treatment depending on whether you were there working or you were there as a tourist. This is the nub of it. Your argument is what you get with ACC is of a measurably different quality and level of support than what you get in other aspects of the system. So the question then is, what is the solution? And is it just extending ACC? And I suppose, Warren, risking that it would be swamped, and therefore the amount that is spent on the individual and the support that is provided to the individual may get eroded away. Is that necessarily the answer?
Well, you've raised some of the issues with the expansion, which is why what I'm saying is that we should plan this very carefully and expand it over the next 2 decades. What we have to do is to have a really good conversation as a country. It's not something that's going to happen in the next 2 months and lead up to the election, but it's something that's going to take a long time about how we do this. Because what we know, it's not just about the level of support and it's person-centric, it's the outcomes. If you actually get the support to go back to work, you end up going back to work. If you don't get the support to go back to work, and
so rehabilitation, quite intensive rehabilitation.
Rehabilitation support, so social support, financial support, rehabilitation, and treatment are the key things. And we know that when we wrap these all together, the people going through that system have much better outcomes than those who are sort of left to navigate it by themselves. Because technically you can get all those things. You just have to go to 6 different agencies and probably litigate something against each of them. And it's not done in a way that's very easy and accessible. And that obviously has impacts on who has access to these systems.
So what you're saying is ACC is the best example of rehabilitation. And the question then is whether what it does can be extended to those who need rehabilitating from a different kind of situation.
Yes, but it's not just rehabilitation. It's people who are born with disabilities. They don't have, they don't like the word rehabilitation, and they don't want to be forced into something where they're sitting in a room detangling headphones, because that's what it used to be. So we need to be careful about how we construct the system, how we expand the system, and then how it actually works. And we need to measure that over time and amend it accordingly.
Isn't the argument just that the cost, were it to be opened to every situation, the concern is the cost would sink ACC. Now let's talk about how it is financially structured. It has a large investment fund. It is probably one of the richest investors in the country, sitting around 44 billion, probably going up and down with current events. And that is because it needs to be, or it is required to be, in a situation where if it had to pay out everybody tomorrow, it could do so, right? So it invests and keeps a solid block of funds for that purpose. What would happen, however, if a significant portion of the, what's the annual health budget?
17 billion or something,
What's the social development budget?
I don't know.
14, 15,
Probably,
higher,
I don't even know.
Higher. More billions than we could add up. What happened if a significant proportion of that gets transferred across onto ACC's books?
Well, what we don't want to do is transfer all that across overnight, because that would be fairly counterproductive. I think we need to step back and think about, first of all, why do we have this fund? So in 1998, they introduced privatisation. The national government did that, and the idea was we have to have enough money because we're an insurance company, and ACC had to compete, so therefore it would do the same. And then the Labour government came in and they kept that going. Now, there's people who suggest they shouldn't have, but we have now a $44 billion fund. And the question is, what should we do with that? And what I'm proposing is that we grow that fund over the next 15 years as we expand the system out, and we do it in a sensible way. And the good example from how we fund ACC is that about last financial year, around $3 billion was collected from levies. About 1.4 came from the government, and about 5.5 was return on investment. So all up,
$5.5 billion. So that fund is actually paying. It is annually paying for these treatments to be done. That is its value. It's not just sitting there as a backstop.
Yes.
It is directly contributing.
It is. So when we look at it, we had something like $9.5 billion in income into ACC, and then we look at how we spent that money. So we spent about $4.5 billion or $4.4 billion on providing entitlements to people, and about $1.1 billion on infrastructure and ACC operational costs. And then we put the rest back into into the investment fund, and obviously there's a little bit of cash reserve. So that's a fantastic funding model. So when we look at innovating funding, what we've got going into that is we've got tax, we've got levies. So taxes are collected through the government and passed out. We've got levies and we've got return on investment. And if we take that type of approach, if we had, for example, 150 billion in that fund, and it might take us 10 or 15 years to get there, if we had a significant amount in that fund, then we can use that money each year to cover the gap between GDP growth, which is normally around 2 or 3%, and inflation in the health and social services, which is much higher.
How much is inflation each year in health and social services?
Well, it depends on how the rationing tools work. So it can be between 5 and 10%. So last year, for example, in the ACC space, the government's contribution to ACC went up 21%. Which is significant. So they've now said, no, we're going to limit that to 7.5% each year. So it really depends on what those systems do. But if you look at efficiency of systems, that's one thing that's pretty good about the ACC model, is that when a person has to go and see someone and they get their rehabilitation plan sorted out and they get their financial support sorted out and so on, we then have a way that we can move through that system with that person really effectively. Whereas if we're sending them to 3 or 4 or 5 different agencies, each of those agencies is administering that person with significant cost, and there's no link up between them all.
There's a lot of dead loss, a lot of dead weight loss, a lot of costs.
And from a personal perspective, it's a terrible experience.
However, the 5 to 10% inflation increase is significant, however it's caused, and is not going to be made up for by GDP growth in a mature economy, and not at a time when everyone's saying we need to focus on things other than just GDP growth. But yes, what you highlighted is that having built up that fund, more than half of what around half of what it spends comes directly from returns on that investment. Yeah. So could we model something similar in the broader health system, or at least in a part of it? 17 billion, I think we agreed the health budget was for everything it does. 9.5 billion was the cost of ACC, did you say?
The income into ACC.
The income into ACC. That's 50%. That's not a massive difference.
And if we grow that fund, if we set our levies, for example, at 2% of GDP, which is similar to what the original idea was, and we grow that fund for a period of time, the return on investment of that fund will be able to cover the gap between the GDP growth, which is what our tax income is based. Our tax income grows depending on what people earn. So we can cover the gap that way, and that's a sensible approach.
Could we charge levies on top of the taxes we already pay for many health services?
Well, that's a conversation that we need to have. So in Australia, for example, they have a Medicare levy that's hypothecated.
Which is essentially an insurance, isn't it? A health insurance?
It's more of a what we would call a social insurance rather than a pure insurance.
Who does the Medicare levy get charged to?
It goes into the government.
But who pays it?
Everyone pays it.
Everyone pays it.
Yeah. And the whole idea there, and it's not the perfect model, there's lots of different models, and I spent a while looking at them, and none of them do it perfectly. Most of them have boundaries, and the boundaries are pretty significant. But the idea that we can start perhaps with those people with disabilities, and we bring that cohort in first, and this is something that different groups are going to need to argue about, but I've put forward a roadmap and said, here are the choices that you need to make, here's the policy choices that you need to make, and over time you're going to need to make them.
On the illness side, there would end up being an argument, as there is already, that we should be focusing so much more on prevention, and goodness knows, same in ACC and workplace safety. But instead of ending up with a ballooning diabetes bill, we should be looking at preventing the causes of diabetes. Instead of looking at an ever-booming cancer bill, we should be looking at some of the lifestyle factors that can be a cause of cancer. Is there a risk if you grow the fund and expand the cover that people say you're not putting the funding where it will actually make the biggest long-term difference?
Well, Catherine, I completely agree. Prevention is one of the keys to this. But what we don't have is the data set, because when we have to put people in single lineal cause boxes, your need is caused by cancer, by mental health, by work, by whatever. We lose the big picture. Humans are people. There's lots of different things that feed into this. And when we put people in these single lineal cause boxes, we miss the opportunity to look wider and have good data. So if we actually had a single system, I would think that we're probably going to have much better data, which will allow us to do much better prevention. At the moment, we have data from ACC, and everyone's fighting about what's the cause of their injury is. You have the same data from health, and they're saying, well, here's all the issues there. But each of these have reporting biases, and there's a whole cohort of people that don't engage with the health system, the welfare system, or the ACC system. So when we have a single system, we're probably going to have much better data rather than much worse data, which would actually help us look at what I call that multifactorial cause, things where a little bit of it's work, a little bit of it's at home, a little bit it's, you went down to the pub last night, and all these things are all combining to cause whatever the issue is.
The problem is that there seems to be universally an acceptance of rationing in the health system. A lot of it is driven actually by demographics. One of the biggest causes of our ballooning health bill, demographics with an ageing population, and one that's living to be older and older and older and having multiple incidents per life. Hip replacements, goodness, we'll be having heart replacements and, all these procedures as we get more and more sophisticated, that's a driving force of the ballooning bill. And can you have your system and still have rationing?
That's exactly why we can't afford not to do something about it now. If we go down the path that we're going down, the rationing is going to get more and more complex, and it's going to get harder and harder and harder, because there's only so much efficiency gains you can bring out of a health system. We see that all the time. We're going to make the system more efficient. Yes, but,
this isn't efficiency, though.
Yes.
This is about choice
Absolutely.
of entitlement and how many
Yep.
hip replacements you can have if you're playing tennis still in your 90s. God bless you. But that's a kind of a different matter, because what you're arguing is that actually it is all manageable if we save and invest and build a fund. Mm-hmm. But I'm not sure those two trajectories could ever match.
Well, I don't know. I'm not an economist. I've done my best to try and understand how the best approach to fund systems is. If you look at Singapore, they fund their entire health system using sovereign wealth funds, and they've been doing that for a long time. So, there are obviously limits on treatment and what you can spend on treatment, and at the moment those limits are set pretty low in New Zealand, and that causes a whole lot of secondary problems. So the effective rationing is every day New Zealanders aren't getting what they need. But when you look at how that's going to be in the future, we can either do something about it and have a funding model that will allow for that funding growth to continue, or we can have a funding model that's going to contract that growth and say each year we're going to bring it down. And I think most New Zealanders would like a system that's going to look after them and their families into the future.
As you say, you're not arguing for Big Bang either. You're arguing to logically, gradually bring more and more into the system. Yes, that fair?
Yes, and I'm put forward a model to do that, and it's going to be up to the politicians to work out.
Who's got it? Who's seen it?
No one's seen it yet. It hasn't yet been published, but I've been speaking to the ministers about it the whole way through. So all of the Minister for Health and ACC and Social Welfare are all very aware of what we're doing. Everyone thinks it's a great idea. Everyone's saying, but how do we fund it? So that's
it's
really
chicken and egg.
Yeah, and it's not something.
I'm trying to fund it, says Warren.
well, this is one of the key things. Is if we go back to the 90s, there was cross-party support to have a sensible approach to funding the system. To build a model like this, we need everyone involved. We need cross-party support and what I'd really call multi-party support. We need the parties in Parliament to say, yes, here's the vision. We agree on this vision. This is where we want to be in 2040. And what we can argue about is a roadmap to get there. And you can say, well, I want older people to come in first. And someone else says, well, I don't want older people to come in first. I want younger people to come in first. And I'm happy for everyone to have those arguments. And people with disabilities will rightly say, well, we've, half the people on the welfare system, when the Welfare Advisory Group released their report, 53% of people on the welfare system were either living with disabilities or supporting, caring for those with disabilities. And these people have been marginalised for generations. And they'll be saying, rightly so, bring us in. And I think that that's probably a sensible place to start.
All right. The deadline you have for finishing and writing your report, Law Foundation supported report?
It's well and truly overdue. But
today's an important day.
but yeah, there's I'm actually working on 4 different projects at the moment, so that's a little bit hard to keep them all going, and there's been significant disruption.
It's come to define your life in some ways, Warren, hasn't it? Because we first spoke so long ago. We were teenagers. And it was very personal. It started you on this journey. It was your own mother's battle
Yes.
And it's come in some ways. Did you, just as you got deeper and deeper into the system, did you just get hooked on what you saw and just said, look, we can do so much better?
Yes, and the other thing is I haven't given up yet. When someone tells me there's no way this is going to work ever, then I'll probably stop. But until then, I have this ridiculous enthusiasm and belief that we can actually do this. This was the original vision of ACC. And every time we've looked at the social and the welfare and the health system, we've said, let's expand ACC. And we did this in the 80s. We did it most recently last year with the Welfare Advisory Working Group. The OECD did a big review of New Zealand for mental health and said, why don't you just expand ACC? That's the most sensible approach. It's the most efficient when you can actually get people into work. And you look at people with disabilities who are on a benefit, that's the last place they want to be. They want to be working. They want meaningful engagement. And there's a chance that we can actually do that. And so that's why I'm still going.
Thank you, Warren Forster, barrister and researcher.